Hi, I'm Mohamad Mohty from the Sorbonne University in Saint-Antoine Hospital in Paris, in France. And it is my pleasure to be with you at this ASH 2025 annual meeting in Orlando and discuss the perspectives when it comes to the relapse refractory multiple myeloma setting and the greatest advances we've seen in the last few weeks. And this is about, in my opinion, the advent of in vivo CAR T cells, but also the use of T-cell engagers bispecific antibodies in the early relapse setting. So as a kind reminder to all of us, we know that CAR T cells represent a true revolution in the field. It's a single-shot treatment. It's about manipulating our own T cells, the T cells of the patient, to educate them, to engineer them, to reinfuse them, and allow the killing of the malignant myeloma plasma cells. But this process is sophisticated, quite complex. It requires several weeks. So if you're able, by just using a drug, giving a drug, and all of the process is happening in vivo, in the body of the patient, this would be a great advance. And here at ASH 2025, we've seen the proof of concept, the first data about using such technology, and apparently it works. It is safe, it is effective if you look to MRD negativity. So something really brilliant for the future. We also know that beside CAR T cells, which have shown great efficacy in relapsed multiple myeloma, we have T-cell engagers. Lots of great results in the very advanced, heavily pre-treated patient. Why not moving them into earlier course of the disease, especially in early relapse, let's say first or second relapse? And this is about the results of the MajesTEC-3 trial. Again, another late-breaking abstract at ASH, showing that the combination of an antibody, an anti-CD38 monoclonal antibody like daratumumab plus teclistamab can lead to dramatic improvement compared to what is currently used, the standard of care. So this is really very exciting, and I think the treatment recommendations algorithm are likely to change in the near future if such combination is approved. But it's not only about bispecific antibodies combined with daratumumab. Now we have excellent data combining two bispecific antibodies, but also even with trispecific antibodies targeting two antigens with one molecule. So also very promising data in very high-risk situations like extramedullary disease. But I think the bispecific antibodies are now being also combined with the classical agents like proteasome inhibitors, elranatamab plus carfilzomib, or plus pomalidomide. So you can see now we're trying to use the best of immune therapy and combine it with the other agent. And at the end of the day, the goal is to design and develop the most effective but also the safest combinations for a given disease status in a given patient. So that provides lots of options to a patient, and this is really very good news. Of course, we should not forget the development of antibody-drug conjugates like belantamab, which are very interesting because you can likely deliver these agents 3-4 times per year, which is very interesting in terms of quality of life of the patient. Of course, we need to be aware about the risk of keratitis, but this is becoming more and more manageable. And this is a similar story to what we've seen with bispecific antibodies and the opportunistic infections, which can be now mitigated with immunoglobulins and optimal prophylaxis. So in summary, the treatment algorithm for relapsed refractory multiple myeloma is being enriched day after day, especially after this ASH 2025 meeting. And I would say, while it appears a bit more complicated on how to choose, I believe it's a very good problem to have and provide more effective options to patients.